Good morning. I'm Karine Tawagi. I'm a genitourinary medical oncologist at the University of Illinois in Chicago, and I'm thrilled to be here with Dr. Brufsky, and I'll have him introduce himself briefly, and we're going to talk about some exciting
Sure.
data in breast cancer.
Sure. My name is Adam Brufsky. I'm a professor of medicine at the University of Pittsburgh. I used to be a GU medical oncologist, actually. That's how I trained. I was probably an academic. I was in academics at Pitt for about a year or two, and they needed someone to kind of found a new breast program down in our obstetrics hospital. So I became a breast cancer
Oh,
physician. And I ran the comprehensive breast cancer there for 25 years. I recently stepped down. But I've done a lot of work actually over the years in a lot of the topics in breast cancer, most of the major clinical trials that we've had over the years.
wonderful. Well, great to have you, and I'm excited to talk about some of the data that has come out at ESMO and what you're seeing in practice. I would love to hear what are some of the biggest challenges that you're seeing in metastatic triple-negative breast cancer currently.
Yeah, the biggest challenge is that really there's not a lot of active drugs. I think that's probably our biggest problem. I think right now, I mean, just to kind of give you some context, metastatic HER2 positive disease, the median survival probably is in excess of 5 to 6 years. I mean, I think we have data that at 8.5 years of follow-up on Cleopatra, which is a first-line trial of pertuzumab, trastuzumab, and docetaxel, that median PFS was on the order, or the median, I mean, a third of the patients are still alive. And in fact, most patients actually die of CNS metastasis in HER2 positive disease. ER positive disease, same thing. You look at CDK4/6 inhibitors, most of the big trials, we're talking now 5, 6, 7 years median survival. Triple negative breast cancer, though, the best we can do right now is 18 months to 2 years. And I think that really that's it at this point in time. At least the best we've done is about 2 years. And so we really need agents that do better both below the neck and above the neck, because a lot of people die with brain metastasis too in triple negative breast cancer.
Mhm.
But that's really probably our biggest challenge, is finding drugs that work well, kind of like, with extended therapy, kind of like, all of the, like, for example, trastuzumab deruxtecan,
Right.
for HER2 positive, or CDK4/6 inhibitors for ER positive. We just don't have a drug like that yet in triple negative. We're getting there. I
Right.
think we're getting there. I think, clearly the data with sacituzumab govitecan, which I've been heavily involved with as one of the
Mm.
investigators on several of the trials, really, I think, has changed to a small degree. I mean, it's again not, I mean, maybe it's changed the natural history probably about 20%, I'd say, of patients with metastatic triple negative breast cancer. That's
Mhm.
probably the biggest challenge, I think, that we have in front of us, is really finding agents. I mean, I'll give you an example. I'll give you a negative trial we had in ESMO, just to tell you the challenges. I mean, we
Yeah.
all were very, very excited about the use of PI3 kinase inhibitors. So there's a
Mhm.
PI3 kinase inhibitor called capivasertib, had really, really nice randomized phase 2 data that were presented, and I think it was published even probably about 4 or 5 years ago. And that led to AstraZeneca doing an enormous, not enormous, but about an 800 or 900 patient trial
Mhm.
of capivasertib and paclitaxel versus paclitaxel alone as
Mhm.
first-line therapy for metastatic triple-negative breast cancer. And that was presented at ESMO
Mhm.
actually 3 days ago, and there was dead negative. No difference whatsoever. The median survival in both arms was about 18 months. The median PFS was about 4.5 months. I think 5.5 months. I take that back. But the thing is that that's our problem. We don't have agents like, we don't have an agent, where we see this dramatic difference, like with trastuzumab deruxtecan. We can use trastuzumab deruxtecan in HER2 low metastatic triple negative breast cancer. But really, I think the cornerstone of therapy in
Mhm.
triple negative breast cancer really still is, for those patients that are PD-L1 positive with a CPS score greater than 10, is
Right.
immunotherapy and chemo. Usually, most people get that first line.
Mhm.
If about the 15 to 18% of patients that are DNA repair deficient and have a germline BRCA1/2 mutation or a PALB2 mutation, or even a somatic BRC1 or 2 mutation,
Right.
uh, we use PARP inhibitors, olaparib, talazoparib. I mean, that's reasonable too. But really, it's that second and third line patients that we have sacituzumab. And I think it really is one of the first antibody-drug conjugates that we had that really showed a lot of success. Again, I think that sacituzumab is a drug Like most ADCs, it has a fairly high antibody drug ratio, or drug to antibody ratio is about 8
Mhm.
of SN38, which is a derivative of irinotecan. It's cleavable in areas of low pH. The linker was designed to be cleaved at low pH inside of the cell in the lysosome. But
Mhm.
on the other hand, the extracellular environment of rapidly proliferating triple-negative breast cancer has low pH, right? Because it's very proliferative, you're using a lot of glucose, et cetera. And so as a result, you do get cleavage in the extracellular space as well, getting bystander effects. So cells maybe that have lower levels of TROP2, which is the antigen that sacituzumab binds to, you can actually get some bystander effects. So, the original studies of this drug were done as simple phase two trial in patients with triple negative breast cancer who had 2 or more regimens. And so these are patients with pretty, median overall
Right.
survival
Right.
of about 6 months.
Right.
It was kind of like, I guess, the analogy that GU oncologists get, and I used to do a lot of work with this too, but it was castrate-resistant prostate cancer, before we
Right.
had it. So the mean survival is about, 6 months.
Right.
So again, and it showed median survival of these patients probably in the order of about 10 to 12 months and a PFS of about 5.5 months, which is greater than any other single agent chemotherapy we had. So that led to a big randomized phase 3, which is ASCENT, which was basically, I think ASCENT was about 500 or so, 520, 530 patients, half of which received the standard chemos that you would normally give, gemcitabine,
Mhm.
et cetera, capecitabine, in that third line space versus sacituzumab, which is given day 1, day 8, in a 3-week cycle. And so, what happened was not only did sacituzumab replicate the phase 2 results in this randomized phase 3 trial,
Mhm.
uh, but, give PFS about 5 months, but give an overall survival advantage. It went from about 6 months to about 12 months. And again, these are patients that are already had about a year or two of therapy. So the median overall survival now in metastatic breast cancer patients, when you give them sacituzumab,
Right.
probably, probably over 24 months. If we really did those data now, probably the median overall survival women probably is in the 28 to 32-month range, with antibody drug conjugates like this.
Right.
And the biggest issues though with sacituzumab, and getting into the abstract that we presented at ESMO,
Yeah.
the biggest side effects of sacituzumab really are that it has fairly substantial diarrhea. There's probably like an 8 to 10% grade 3 diarrhea. And there is fever and neutropenia, which we don't like in triple negative breast cancer. We don't like in metastatic disease. We're all taught in metastatic disease
Right.
to use single agents, and reduce the single agent, don't give growth factors, really focus on quality of life, sort of things. And so, that's probably the biggest setback of using sacituzumab. I mean, clearly it has a survival advantage and we all use it in
Right.
this setting, but the issue really is the diarrhea and the fever and
Yeah.
neutropenia, among other things. Actually, there's alopecia, but I think most women, and I don't think we can use cold caps for that kind of alopecia.
Mhm.
So the thing is, what do we do? So we've done a number of abstracts over the years. I mean, so this trial was originally published in the New England Journal of Medicine, I think late 2021, 2022.
Right.
And it was presented actually, I believe, like at a special ESMO session over the summer. Well, it was ESMO 2020, I think it was initially presented. So we're not 4 years later. And I think what we've done is we've really applied a lot of quality of life instruments to it. And I think what we did in this abstract is look at something called Q-twist, which is
Mhm.
really a very old but fairly well accepted way of looking at quality of life. And it's basically time with toxicity, it's basically quality time without symptoms or toxicity,
So
basically. You
important.
use 3 separate things. You use, time in relapse, time without progression and no symptoms, and time with toxicity and no relapse. So you kind of calculate it up. You use kind of a variety of what are called utilities from the literature, saying which is most important to the patient at each time. And the bottom line of the Q-twist analysis is that compared to physician's choice of therapy, I mean, Q-twist was much better. So the
Okay.
times without symptoms and toxicity with sacituzumab was far better. It was almost double
Right. Which is
that
great.
of the physician's choice of therapy. In fact, there's like these are like, we work with kind of these pharmacoeconomic people, and the pharmacoeconomic collaborators said if you have greater than 10 to 15% difference in Q-twist between the arms,
Mhm.
that's going to be considered clinically relevant. I think this is important. I think we kind of, I think it's important, and it's important not only for the approval of the drug and its acceptance by payers, which I think is really where Q-twist analysis is important, But it really does show, I think, that, the drug is having an effect over and above simply just showing that we're not having progression.
Right,
That, in fact, you are increasing the amount of time that someone has without symptoms, progression, or toxicity.
right.
And I think that's what was the most important thing about this
Right.
study.